sort of taking, even if it's just an extra 5-10 minutes, just to build some form of relationship and trust with your patient. Sometimes it might be as simple as finding out, how are the kids? And, sometimes we find that some tips and tricks are really around, well, of course, you have to listen. Sometimes you're pressed for time, but then sometimes what's helpful is just having little, sometimes when you're taking a family social history, I tend to keep a few notes, like, has a 3-year-old, has a new baby or whatever. So when you're having the next visit, you're actually saying, okay, so how are the kids? And so they feel a little more confident in sharing their narratives with you. But I think what we need to, as a oncology community, emphasize to our patients is that just because it's on WhatsApp and WhatsApp is notorious, or on social media, doesn't make it true. And just because somebody on social media says there's a doctor saying 1, 2, 3, doesn't necessarily need to make it true. And I think there's importance to verify. Actually, my colleague this week has been trending on Instagram. He's a obstetrician gynecologist, and he suddenly has a picture of his interview taken from a national media interview. But the caption on Instagram is, doctors in Africa find miraculous way to reduce weight loss. And so I was telling him, hey, how did you get into bariatrics? I was like, no, I've been trying to take it down because I don't know who's, running this. But they just took a clip from his interview. He's not saying anything. So he's just speaking in the background. But then the caption is really around weight loss. Call the link and find out. So really, just because it's on social media, you need to verify. I think that's the take-home message.
You raised a very interesting topic. In fact, is use of social networks to increase awareness about all of these issues of our daily practice. We doctors and the researchers work in the lab, work in the departments. We have our focused job is to diagnose and treat patients. But currently, I think we need an extra time to be invested in increasing awareness on all of these issues using social networks. Because if we do not invest some of our times, one day people are just going to use the information provided, but non-scientists on social networks, and maybe are going to take drugs or something without really any indication, any evidence-based science. So I think young oncologists in Africa have or should invest some of their times to on social networks to increase awareness about these issues and provide evidence-based recommendations for their patients, because patients now have all mobiles, they have phones, and they use them to get information about their disease, about the treatment is being used. So I think we need to invest some of our times in this perspective.
Absolutely, absolutely. And I'm trying to see if there's any other questions, but maybe we can quickly segue into the second part, which I think is going to be of extreme relevance to all of us, because there's some inadvertent errors that we may not necessarily realize. But go ahead, Khalid. Let's
thank you so much. Okay, so now we are going to discuss something more serious for us as researchers and practitioners. It's about declaring conflict of interest. You know that our daily practice is associated and linked somehow with the industry. So the day that you are doing promotion for some new treatment or something that you have conflict of interest, it's okay sometimes, but you need to declare them at least. So is there any danger if we don't make any disclosure of conflict of interest? I think that's the topic of our next slides. So let's start with some basic definitions. Conflict of interest arises when a person's professional judgment, decision, action within the workplace might be influenced or compromised by their personal interests, which encompass family, friendships, financial considerations with industry, or social factors. So you can categorize this kind of this conflict of interest into financial conflict of interest when there is money behind. For example, you are an investigator in a trial and you receive royalties, honorarium from the pharma industry that is building the trial to make promotions for the trial, to demonstrate the superiority of the new drug or something like that, then it's a financial conflict of interest. There is also non-financial conflict of interest, like, for example, you are the primary investigator in a study, and in the same times you are one of the board members of the company or the organization that is currently funding or conducting the trial. There is also conflicts of roles. An illustrative example, for example, when you are a primary investigator in a study and in the same time you are a member of the committee of the ethical committee review board that has reviewed the same study that you are conducting. So this is a conflict of roles. Of course, there are a lot of other types of conflict of interest, and I don't have time to discuss all of them. But the dangerous one are those I am currently highlighting here. Unfortunately, physicians' self-reports of financial conflict are highly discrepant with objective data sources reporting payments from industry. This means that when you publish a study, the conflict of interest you are declaring are not the same that than those you have already declared in open data sources, like in the US, for example. So doctors, unfortunately, sometimes have hidden information about these financial disclosures, which is illegal, and sometimes it might be very dangerous. Also, a smaller monetary amount was the most common factor in this study I am showing here associated with non-disclosure. This means that doctors sometimes they receive some small amount of money as royalties or honorarium from industry, like to make a presentation, a promotion of new drug. But for them, it's okay. It was just a small amount, so it doesn't really merit to be reported, but it's not. Even if you receive only $1 from industry or from a funding organization, you need to declare it. So that's the rule in international standards. All financial conflict of interest influence with the studies report finding favorable to the sponsors. This is okay. We all see this in all the trials we are reading in international big journals of oncology. When you check the conflict of interest, you can realize easily that all of the authors, maybe they have received money from industry. And when you read the paper, you can realize that there are some kind of writing that tries to show that the trial was positive, that survival was improved, was the end point was great. And but when you check the details, and always the devil in the details, you can realize that the study has flaws, has problems, has important design issues, important statistical analysis issues, etc. But unfortunately, authors try always to show the positivity of the trials they conducted when they receive funding or royalties from industry. So the message here for young oncologists: when a clinical trial is not academic, is sponsored by industry, the first thing you need to do when you want to read a clinical trial, a phase 2 trials particularly, is go directly to the conflict of interest statement. If you see that there is something called a third party company that wrote the article, be very careful, because in a lot of cases, in a lot of trials, it's not the authors who wrote the article. It's another company that tried to make the results more positive using a new interesting style of writing. For example, you have a negative result, but they try to make it like it's positive. So be careful about this, because in a lot of cases, unfortunately, when the trial is not academic, authors have not really written the article. They are just verifying the content and approving it, and they added their names there. It's the third company that really wrote the article. So be careful about this. And there are a lot of people talking about these issues globally if you want to check. Um, of course, we need policies. Fortunately, there are policies from international publishers, organizations, etc. But unfortunately, it is not well used in the daily practice, unfortunately. what can happen the day you don't report your conflict of interest? So this is an example of an article that was retracted because the authors or one of the author did not report his or their conflict of interest or their conflict of interest that were wrong. This means that the study was funded, they received royalties, honorarium from industry, but they didn't declare that openly and transparently in the paper. So sometimes this can bypass the peer review process, and later the journals, when they detect that, they retract the papers. This is another example of papers that were retracted from BMG because the authors used or tried to show something related to smoking, and it was tobacco industry sponsored, but they didn't really report that in their conflicts of interest. And fortunately, the article was later retracted. This is also very, 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 very important. This is the most important slide in my presentation. You need to know that most editors of top medical journals, the top medical journals, this means that the journals where a lot of great phase 3 trials are being published and that are currently changing our daily practice, because based on these journals, we make new international guidelines for our daily practice. So these editors receive higher honorarium and royalties from industry. And this is done to make publication process more easier for those companies. And I will not go into those details today. It merits another presentation focusing on the money received by international journals to make the process of publishing maybe negative trials or flawed trials more easier. So on the right, if you still remember, one day I say there are a lot of predatory journals you already know, they don't conduct peer review, but there are also the big predatory journals that you need to know. And I will not go into more details about this right now. There are some great institutions that use policy to recommend, to make solutions, to resolve issues. And in this case of the Sloan Kettering Institution, there was an oncologist, cancer researcher, that published an article without declaring her conflict of interest. And the day they discovered that, they asked to make a statement publicly and to make a corrigendum in the journal. So this means that if institutions survey their researchers and oncologists adequately, we can somehow at least declare the conflict of interest of all oncologists properly and openly, and also immediately when you are publishing the paper, because it's not, it should not be done after you publish the paper. It should be done the day you are conducting the research and submitting your paper to the journal. Now, there is another chapter. If you have any questions, comments, I will be very happy to receive them.
Thanks so much, Khalid. And maybe I can actually just use this time to reflect on some of the work we'd done earlier in the year. So we did a review on conflicts of interest as far as oncologists in Africa are concerned. And I think one of the issues that we do realize that we're really trying to look at our relationship with pharma. And I think many oncologists don't necessarily realize the potential sources of conflict. And so we sort of put these down to 4 main areas around education, clinical care, research, and policy. Now, sometimes the challenge, of course, is, as we said, we are in diverse resource environments. And so sometimes, we do need pharma. They're not necessarily the antichrist, for want of a better word, but they do have their role, and we do need to be conscious of that in terms of declaring interest. So Exactly. And sort of Adam was raising the point around COI can be financial or non-financial, and that's absolutely correct. So in terms of education, what we try to look at, what are some of the potential sources of conflict? Things like sponsoring continuous medical educations. Sometimes if you're having your short-term clinical observership or long-term trainings being sponsored by pharma, or sometimes funding educational conferences, those are things that you do need to think about in terms of potential conflicts. And then in terms of clinical care, even something as simple as having a clinical meeting where you're having your snacks provided, which
Yeah.
of course, increases the compliance with people
Yes.
participating, or having sales representatives visiting clinics, or having some of the experts working at pharmaceutical companies or buying clinical equipment, or donation of cancer medicines already in itself raises a potential conflict. And then looking at, of course, you've talked about the research, Khalid, where you're talking about clinician-initiated research projects or recruiting patients for industry-funded clinical trials or sponsoring research conferences or training. All of these are potential sources. And then sometimes we even go as far as, for policy, where pharma is paying for, review of the reviewers of the clinical guidelines, or sometimes hiring policymakers into pharma positions, or so all of these, not to say that they automatically are a potential conflict of interest, but to recognize that we do need to be aware that we are an emerging market. We are definitely having more engagement with pharma. So some of the potential strategies that we could maybe think about, and maybe I'd also be interested to hear what people on the call have to say, is just increasing awareness of these potential conflicts all the way from medical school and postgraduate training programs, and then also studying the interactions between how is pharma, engaging with clinical care, but then also looking at, even if you're going to sponsor, clinical meetings, then you should still have the scientific committees really deciding on the content. Sometimes pharma want to sort of bulldoze and say, we are supplying this, so we're going to provide our speakers. So how we mitigate that from some of the professional associations is that we have a final say in who's actually giving the talks. And then also looking at how do we then increase or support investment in country or in facility investment, rather than having pharma consistently supporting our tumor boards. Why don't we try and view it as, quality improvement measure? That's, standard of care, right? And so it's really looking through some of those concerns that I think would help to go a long way. I'm seeing Adamu. I don't know if you want to make a comment. Adamu Adise.
Yes, Miriam, thank you very much. I was actually just asking. I think this is a conflict of interest is a very vast, and it can also be deep. So I was wondering, apart from declaring a potential conflict of interest, if there would be other ways of managing that, and you have already mentioned some of the strategies. So I was contributing, but I was just adding to the points that this is a very important topic that we need all to be aware of, and alert our peers as much as possible. Thank you.
All right. Thanks.
That's a very important note. And I think Dr. Miriam has already shared some very important thoughts about this. I think maybe starting from undergraduate studies in mid school, by providing courses on ethical considerations in trials, in our daily practice, conflict of interest, and everything related to this kind of issues, I think will be great for the future in Africa. The day that an oncologist receives money from industry, I think it will be late to resolve the issue adequately. But by increasing awareness and alarming future oncologists, medical students in mid schools will be great. Policy also from international organizations like the AWATEC, and also as we did right now, increasing awareness of oncologists about these issues using distance education approaches. Then I think these are all great, but we need more serious policy from the government maybe, and I don't know. It depends on countries. It depends on seating. For example, in Morocco, I have participated in a lot of oncology meeting, and unfortunately, all of oncologists, including professors in academia, they didn't really declare the conflict of interest, because for them it's okay. It's not something unethical or it's illegal. They receive money from industry. We all do sometimes, even if it's a small amounts. But unfortunately, this knowledge of sharing and declaring this potential conflict of interest publicly is not something frequent in our city. Unfortunately, how to do that? To be honest, I don't know. We propose some solutions like policy, education, etc. But we still need more serious strategies for the future.
Absolutely, absolutely. And I think, just as you said, increasing awareness and having these conversations and forums, and because we assume that because if, X company is going to fly me to whatever, I am not going to be influenced by, to prescribe their medication. We're only human. And so really recognizing the role that pharma has played in helping to support and advancing healthcare, but also really being conscious and intentional in terms of our interactions with them.
Exactly.
I think we are running a little short of time, so we'll quickly do a whistle-stop tour of the last bit we wanted to handle this evening.
Okay.
Go ahead, Dr. Khalid.
Yeah, thanks. So now we are going faster, in fact, and we are going to discuss some other ethical issues in human-based studies, particularly in the field of research, not practice. In addition to what you already know, based on our webinars and your own training about ethical issues and research integrity issues in the field of oncology, there are other issues that you need to know. For example, ethical review committee approvals, patient consents, etc. And here I have highlighted some very, very important issues in the field of interventional studies, like patient safety issues, failure to follow protocol safety requirements, failure to obtain proper informed consent, failure to obtain appropriate approval for research, failure to report adverse events, etc. So all of this may harm our patients, may harm our academic career. So we need to talk also about these issues, so we will prevent retractions of our publications. I checked this important study. It was a review article. I tried to map research misconduct and data fraud in clinical trials to investigate the prevalence and also the causal factors of these issues. As you can see here, it may be very, very serious. For example, when you falsify data to have more patients enrolled in the trials. Unfortunately, some investigators try to falsify the inclusion criteria so they can have more patients into their trials to have the adequate sample size so they can test their hypothesis. And this is unethical. You should not fabricate or falsify those data to have more trials being published. And as you can see here, the outcome of doing so may be very serious. There are a lot of investigators in the field of oncology that are currently in prison, or they were in prison because of falsified clinical trials. Unfortunately, we are focusing more on providing positive results than improving the quality of life of our patients. So when you have a patient with cancer with highly aggressive disease, and you do this kind of things, I think it's very weird how humans are manipulating humans, particularly cancer patients, which is a category of patients with highly aggressive disease, to do this kind of trials. And unfortunately, a lot of trials are being published using this way. And there are some cases, as I said, of serious misconduct. Here you see prison sentence dismissed from positions, resigned positions, etc., etc., etc. So when you do not respect the Helsinki Declaration, when you do not respect the Ethical Review Committee criteria, when you do like this kind of falsification and data manipulation that it can be very serious for the patients and also for your career. This is an article that was published as a case report in diagnostic pathology. And unfortunately, when you read the paper in the consent of publication, you see that the authors provided a statement that they had the consent to publish. But later, the journal made an investigation, maybe because the patient family has contacted the journal or for other reasons, maybe also because of the PubPeer initiative that we discussed previously. They didn't provide any written informed consent. This means that they published the data of the patient without having patient consent. So this is illegal. And when you do that, the article is going to be retracted without any discussion. So always the message here for you oncologists, when you want to publish a case, a very interesting case of a cancer or something like that, always get a written informed consent. It's not an oral informed consent. You need to have the signature of the patient or his family members who are responsible if it's a child, and you need to keep a copy of the patient consent, because sometimes the journal will ask for an original copy. So if you don't have it, then your article is going to be retracted. So be careful about patient consent when you have case reports to publish. Always also when you use human data in your research, for example, you are conducting an observational study or intervention study, you have human participants, always get ethical review committee, because based on the law in each country, it somehow vary, but the international standard is that you should not and you cannot publish any human data without having ethical committee review approval. And always get a copy of this printed and scanned and conserved somewhere, because the journals, the day they discover something bad in your design or in your study publication, they will ask for an original copy scanned, and you need to have this. This article was retracted because the authors didn't have the ethical committee review approval, and they published the human data. So be careful. One message to all your oncologists here with us today: do not accept to collaborate in any project if the principal investigator don't show you an original or a copy of ethical review approval. This is very important, because if you are a co-author in an article and later it is retracted because of this issue, you have no right to state or to say to the journal that it was the error of the principal investigator. You are also concerned, and you are also a participant in the project. So always, always, always have a signed copy of the ethics committee review approval. This is another example of articles that were retracted. It's in vitro based study using tissues from humans, and they didn't publish. They published, in fact, the paper, but they didn't have ethical review committee. And later, the journal was contacted, and the article was retracted. There are a lot of cases like this on Retraction Watch database where you can get information about this. This is just another example to say that it's something frequent but really rare. This is another example of translational studies that were published, and there is now evidence of having ethical review committee, and the article was retracted later. So the take-home message again here to young oncologists: it's not retrospective review. You need to have the ethical committee review approval before you start the study. If your study is done, you have no right to ask for a retrospective review. Okay, so always before conducting, studying, collecting data, enrolling patients, have the committee review of your study design, because later, if the article is published, and unfortunately, editors do not check for that open submission. It's rare that a reviewer or an editor asks you about ethical review committee approval before it is being published. It's until it is published, then unfortunately, problems arose. The famous Journal of Clinical Oncology, it's a very big journal of our daily practice that provides very important recommendations, international phase 2 trials that improve our patient cares. And even if big journals sometimes authors can publish studies without having ethical committee review approvals. But fortunately, as I said, when the journal is good, when the journal is published by an international organization like the ASCO or other organizations that really care about these instructions and ethics rules, the article fortunately was retracted. But if an author or a clinician, a daily practitioners that use the data from this study before it is published, then it might harm your patient. This is the bad thing in clinical research. In fact, is that when you falsify data, when you do like this kind of fabrication of issues, and the article is published and is used for international guidelines, it might hurt your patients. Your patients already suffer from cancer, and you are going to make them suffer more from absence of accurate evidence published in this kind of journals. So this is just to say that even international big journals sometimes publish studies without having ethical committee review. The take-home message today for our oncologists before finishing this webinar: don't be involved in paper mills. This is something that you should not discuss. It will ruin your academic life sooner or later. So don't think about it, all right? If you know someone who is doing this kind of research, try to increase his awareness about the issue, because later the article is going to be retracted and his academic life may be ruined because of that. Also, you need to know that publishing fake data will negatively affect your patient outcomes. This is our daily practice. You don't use evidence to treat your patients. You are killing them. You are decreasing their survival. You are not improving their their outcomes. So please use accurate science to treat your patients, and always get written patient consent for human-based studies whenever it's required. If you want to publish a case report, you need patient consent. If you have an original study, you need ethics committee review. And always patient consent are required when study is prospective. In the case of it's retrospective, then the ethics committee review can waive the importance of this kind of consents. Do not collaborate in any human-based project without reading the details of ethical review documents. This is very, very important. I see a lot of papers being distracted in some similar setting, like in Morocco. People are being added into projects without checking the details of ethical review committees, of statistical design and everything. And later, when study is retracted, they say it's the issue of the first author, of the last author. No, no, no. It's the issue of all authors, and you are all responsible of the people you are co-authors in. And always report your conflict of interest. Today, I reported my conflict of interest. I take enough time to report them. It's okay. I received money from industry, from international publishers, and I have now associations that might negatively impact the content of my slides. And it was okay. I reported them in detail. So always take time to report your conflict of interest. And I think this is the first step to improve our science in Africa. This is the last slide. Maybe based on the webinars we did together, the issues in oncology you already now are here, and the part of the iceberg that is hidden is the other issues in oncology you need to know. There are other issues that you need to know. Unfortunately, we are not perfect. We are humans. We have a lot of issues in our daily practice, and in developed countries, concerns of research integrity are a daily discussion. No one is considering them as something hidden or to be neglected or a taboo. It's something that we need to discuss every day in meeting, in oncology conferences, in our daily practice. In Africa, it's only just the beginning. I hope that all more oncologists will care about research integrity in the future, and research integrity in under-research setting is an urgent need. I think we can publish on these issues. We can do research on these issues, and I think this defining the solution is to improve our research, of course. And we cannot advance in cancer research without diagnosing issues and proposing solutions. The next webinar will be about something very interesting, particularly addressing the issue of gender inequity in oncology. This time, our colleague from Belgium, Dr. Lauren, will join us to discuss some very important information about this issue. I will be discussing also our Georgina study in North Africa, and Professor Miriam Motibi also will join us to discuss gender inequity in sub-Saharan Africa. Thanks again for joining me today. I would like to thank all collaborators in my projects, my institutions, the Our Team for the great events we did together, and for all people working to make this webinar successful, Bill Mira and her colleagues. Thanks again, and I will be very happy to take any other questions.
Thanks so much, Khalid. I think really you've touched on the highlights really around fake news. And I think the take homes, as you said, just because it's on social media doesn't make it, legitimate. And then also maybe being more aware, and we've discussed this at length around potential pitfalls or opportunities for conflict of interest, but then really also looking at the ethics of our practice. Sometimes we think about ethics like this very egregious, infractions of patient care, but ethics comes from simple things like, even in terms of, some people say, you're collecting your data, and sometimes you are so busy on clinics so that you maybe come in the next day and you try to maybe massage the numbers a little, right? It's as simple as that, all the way up to blatant, manufacturing of results. So it's really around, how do we inculcate these practices into our daily care? How do we have integrity, whether it's in our clinical delivery, whether it's in our research methodology, and the day-to-day consistent efforts that we do that ultimately make a difference in terms of the overall picture and improvement for our patients' care. I think one of the things I know we're a little over the hour, but I think Resea had a sort of a brief comment on just asking about the baseline requirements of an ethical committee and whether it requires some religious figure or lawyer. And of course, what happens is, if you're looking at the functions of the ethics committee, we're really trying to look at how do we conduct research that is safe for the community, and that's ultimately going to interact or affect the community. So we do, depending on where you are, most of the time you will either have community leaders. In many contexts, this does translate to religious leaders, but then it does need to be constituted sometimes even with patients or patient advocates. And so those are some of the considerations that you do need to have, because we can be having good science, but what is the impact on patients? And so those are some of the things to consider. Khalid, I don't know if you have any other comments regarding the ethics committee constitution.
Yeah, we have already addressed this and provided very interesting thoughts. The thing I want to share and really insist on being serious in conducting clinical research. The final destination is our patients. So when we do research, it's not just to publish. It's to improve our patient care. And unfortunately, the patients who are treating are not easy patients. They are cancer patients. They have aggressive disease. So the day you want to make a progress in oncology, the day you want to make a design of study, always think about the final destination, which are patients. A study that will hurt patients, always forget about it. A study that will improve patient care, then do everything you can to make the study successful. I totally understand that in some setting, in some countries, ethical review committees do not exist. In some setting too, it's difficult to have them. There are conflicts, there are problems, but always try to at least respect the Declaration of Helsinki, not to hurt your patients. I strongly believe that there is progress in Africa related to ethics committee review. There are a lot of new ethics committee reviews that are being developed. So try to get their opinion about your study. But before doing so, try to write the good study protocol, because when you are writing a good study protocol, then you are respecting the ethics, of course, because it's a part of the the protocol of each original study. And do not start any study without having enough knowledge about how to make a successful protocol. Regarding ethics committee reviews, sometimes it takes time. I totally understand that they are volunteers. They are not paid for the job they are doing in the ethics committee review boards. They are volunteers, as I said, so sometimes they don't have time to review a lot of protocols in time. So it's time consuming, and you need to prepare your study design in time, because if you are building a study next October, you want to enroll patients next October, you should not start now applying for an ethics committee. You need to apply 6 months before to have enough time to make things okay. So always take enough time to make great protocols, to submit always to research ethics review boards. And in the case of if your law do not require ethics committee reviews, for example, in the case of retrospective studies, if case of survey-based studies where there is no interventions, no things that can hurt your patients, then you can sometimes bypass the ethics review board. But this depends on the law in your country. In Morocco, for example, we can publish survey-based studies without having ethics committee review, but always have their opinion before publishing your data.
Yeah. And I think that's a good point, Khalid, because sometimes we think, okay, this is not involving anyone, so I can go ahead. You still need to go, you still need to apply for exemption. And so somebody, hopefully those take a shorter period in terms, rather than a full formal review. And what would happen is they would still, do a quick pass and sort of see whether this, passes the sniff test, as it were. Like, is it, fine. But then also thinking about your setting, I know many countries don't necessarily have, I mean, we do require ethics, but we have very few ethics boards. So sometimes it's also looking at, as Khalid is saying, giving yourself enough time and looking at how do we then tap into whatever the regional ethics committees and stuff are. But you do need that whole concept of a bit of a lag time. But I mean, in terms of most of the time, the ethical boards are really coming from a place of patient-centered, like really trying to identify what are the ethical issues and risks, and providing advice sometimes on how to resolve these issues. So if you also start, even within your protocol, thinking about how do I resolve any potential, concerns that might be ethical or border on, or even consult from your mentors around how to resolve this. We've had issues around, should we, compensate patients if you've come in for, care? Is that, inducement or incentive? So those are some of the things that you do need to sort of tease out, even as you start to prepare your protocol. I see, Kudus, you have your hand up. Kudus, maybe we could have a quick, I think you wanted to make a comment or a question. Oh, is it, or was he, we'll assume you were supporting the role for integrated.
Maybe he's having internet challenges.
Yeah.
Yes, yes, I've been experiencing that, yeah. It's off the screen now, yeah.
Okay, all right. Yeah, no worries. I think we've sort of planted the seed, but I think going forward, it's really starting to interact with these key concepts around conflict of interest, trying to identify and perhaps potentially mitigate some of these, really looking at how do we build ethics as an integral part to all we do as clinicians. I think really summed up by primum non nocere, first, do no harm. And so whether it's in our clinical practice, whether it's in our research, whether it's in collecting teams, it's really about striving to give the best for our patients. So just to thank you all once again for your time and a very engaging and fascinating discussion that we've had, and really thanking the team behind the scenes, Belle, Sky, Hadija, and everybody else. And really you, the audience, for your time and commitment towards, participating in these sessions. And just to invite you all next for our next time, really looking around, doing a deeper dive into gender and research in Africa. Thank you once again, everyone. Have a lovely evening, morning, wherever you are. Enjoy the rest of your day. Stay safe.